Hi, colleagues. I am just finishing our, I am just finishing our class for today. I appreciate your patience with this. I know it's not that fun to have to listen to integrity, so we will get right through it here. Okay, so perinatal mood disorders. What are we talking about here? We always really think about depression, but depression, anxiety, OCD, PTSD, and postpartum psychosis are all perinatal mood disorders, right? And obviously, almost a quarter of women will have some kind of symptom of any of these during pregnancy. And then postpartum depression also. So this is definitely a serious thing, and for postpartum depression, we can use that Edinburgh postnatal depression scale. So that's something, but really any kind of depression assessment is warranted, definitely. So that is part of care management, is really keeping that uppermost, knowing that it's so prevalent, and educating as far as what to look for. Often important to educate the significant other in this. So, so a lot of times we'll give some SSRIs, even though SSRIs can cause babies to have some withdrawal symptoms after delivery. You have to kind of do a risk-benefit analysis. So especially in that third trimester for the SSRIs, because we don't totally know the safety, but you really have to look at the safety of mom and how mom is able to handle things. So sometimes we can't. Usually we'll go down to one med if she's on many meds. So, and you can, I'd like you to look at the box 31-1 on page 740 for the FDA risk categories during pregnancy. I think that is kind of interesting. So, nursing interventions, when we do have someone, anyone who's pregnant needs to be educated about depression. Okay, but if you have someone who is diagnosed, for sure, talk about medications. Some women feel pretty strongly about not taking SSRIs. There's still a stigma with mental health issues. We have to, of course, approach it just like it's any other disease process. And if there are alternatives that she wishes to use, we have to respect that choice, but also give her information on what is safe and what is not safe. And then, of course, the most important thing is to maintain a close relationship, and where we're really in touch with that woman on a regular basis. There is a nursing care plan that you can look at for more information on page 747 if you choose to. All right, so wait, did I really want that? Hold on one sec. I feel like we're okay. Now we'll talk about about drugs in pregnancy, perinatal drug use. We have to have a high level of suspicion, and we have a great latitude for testing moms. You guys know, if you're in OB, we've been talking about, we have a blanket consent on the unit. Anybody who comes in, we can get a urine drug screen on for very pretty much vague reasons, but some of them are no prenatal care, or getting first starting prenatal care kind of late into the into the second trimester, or a lot of missed appointments, sporadic care, poor nutrition, if there's marital family disputes, if there's been any kind of problems with law enforcement. These are reasons why we can test a mom anytime she comes in. And some moms we test every time they come in. So, and they're even tested frequently in the clinic too. So what we see a lot when we talked about perinatal mood disorders, dual diagnoses are very, very common in any group that has substance abuse. Usually, a lot of times we see patients who have a psychiatric disorder that are kind of self-medicating with drugs and alcohol. So 15% of all pregnant women have a psychiatric disorder and are using drugs. So what are the risk factors? Can you think of what risk factors could be? When you think about drug use, you're thinking about usually a younger population. A lot of times people who don't have a lot of education, and obviously poverty is a risk factor, definitely. How do you assess if you have a patient? Everyone should be assessed for drug use. And so how do you assess that? You ask directly. When you're getting a history, you say, any drug use at all, any street drugs. You want to make sure that you don't just think about street drugs, though. A lot of times they're misusing prescription drugs. So what we see as far as the types of drugs that we use, that are used during pregnancy, it really pretty much depends on money, and how much money. Is heroin cheaper? Is meth cheaper? Cocaine tends to be a little more expensive, evidently. I'm not totally sure about that because I don't have a lot of history. But a lot of what usually determines what they take is often connected to how much money they have. So barriers to treatment, if we're talking about treating for drug abuse and or psychiatric care, we know that mental health services, the funding has been cut to the bone. There are long waiting lists. If we have no health insurance, or if there are judgmental providers, that women will not go and seek help. So these are all barriers that we want to try to move over. Legal considerations. In some states, we think that is child abuse or neglect under civil child welfare statutes. And if this is the case, we will file a form called a 960. I think you guys heard about this in PEDS just recently. And if we have positive mom and newborn baby drug tests, we will report that to social services, and they are mandated to follow up. We are legally mandated reporters of child abuse. And so if you are doing some of this reporting, it can cause some problems in that provider-patient relationship. But if you're a mandatory reporter, you definitely have to do that reporting no matter what. So commonly abused drugs, you can see the list. Tobacco, it's a legal drug. What we see, intrauterine growth restriction, a lot of times. Preterm labor, a lot of moms who smoke go into preterm labor. If you have decreased perfusion to the placenta, because we're taking away oxygen, and some vasoconstriction with nicotine, we're looking at possible higher risk for abruption also. Alcohol is the most common preventable cause of cognitive disability. We know that alcohol can alter development and can affect actual maturity. Again, we see IUGR for this, not good. It will, again, stress out that placenta. Marijuana Actually, this is probably the most benign drug. Unfortunately, it is illegal. It limits blood flow, again, depending upon especially how they take it. But let's see. Cocaine, you have vasoconstriction with cocaine, you have decreased uterine blood flow, we see miscarriages, preterm labor, abruption, small for gestational age babies, intrauterine growth restriction, intrauterine fetal demise, drug-addicted baby, and tobacco is another one that also, it's terrible withdrawal for babies. Not a pretty thing. Methamphetamine, we see brain abnormalities with methamphetamines, definitely baby addiction, preterm labor can happen. Opioids, we see fetal dependence on opioids, and then any prescription drugs can have issues depending upon what class they are. All right. Care management, we do screening, urine screening on admit, and then we will also do urine, so we urine screen mom on admit, then we will screen urine for baby. We want the first urine and then the first meconium. Meconium is sitting in that intestine, and it kind of provides a history of the drug use that mom has. So if the meconium is positive, we know that there's been some prolonged drug use during pregnancy, for sure. We also screen by using maybe some questionnaires. There's 4 PS Plus screening tools, and you can see that box 31-4, page 753. Some of the assessment things that we will do, we will get ultrasounds to see how this baby is doing. We can look at, definitely sexually transmitted infections tend to go along with this high-risk behavior, so we'll be checking that out. We want to know how healthy mom is. One of the things we'll look at is a CBC, and then NSTs, biophysical profiles. We'll look at all of those things. We really want to watch that placenta especially. And how we screen is going to be directly related to the drug or drugs. Oftentimes there's a mixture that mom has been taking. So medical management, some of the interventions, ACOG, and which is the American College of Obstetricians and Gynecologists, and AAP, which is American Association of Pediatricians, they state that what is most important is that mom gets treatment and not get punished, not get jail time or punishment. And so doing screening during pregnancy, giving detox, trying to manage withdrawal symptoms so mom doesn't go into preterm labor, and try to get mom as healthy as possible during the pregnancy, and of course afterwards too, if it's still an issue. I know that one of our moms was getting methadone, which is something that we give to try to get mom off narcotics, heroin, some of that kind of stuff. Nursing interventions, we have a plan of care, plan for pain, because especially if mom is taking opioids, if she's addicted to some of these things that blunt pain, and she's not taking anything, she may have some major pain during labor, and so we need to really be thinking about getting an early epidural for her. Educating her on the effects of the addiction on the fetus, really important. Some more nursing interventions are in box 31-5, page 756. And then follow-up care, we definitely want social services to be following up with that mom, to assess the home environment, make sure that there's help for the baby. Home health visits, possibly child protective services. If the addiction is really bad, if baby is going through a lot of withdrawal, obvious problems. I know we've had moms who've come in just totally whacked out on meth and other things. They will sometimes not let the baby go home with the mom. They put the baby in foster care. The ideal is that they get mom treatment and then mom is able to take the baby, but it doesn't always happen that way. Then children tend to go back and forth in the system. So it's not a fun thing. In the past, women were told to choose between psychotropic medications and breastfeeding their infant. Current beliefs are that although most drugs will diffuse into breast milk, there are few instances which breastfeeding must be discontinued. Several factors are known to influence the amount of drug an infant will receive via breast milk, which is not one of these factors. And on NCLEX, you will never have a not one of these factors. You would probably be more apt to have, which are the factors that affect this, select all that apply. But today we have this not here. So the amount of milk produced, the composition of the milk, the concentration of the medication, offering of single or both breasts. So what would you think would make a difference? D, offering single or both breasts, definitely. And then, happy Tuesday. Study hard for the test. It's not easy, but I know you guys can do well. Okay, have a great day.